So we want you to imagine the birth of a baby. Mother and baby going home shortly after the birth. Baby progressing through milestones, feeding, walking, talking.
However, imagine if your baby spent the first 8 months of his or her life in hospital.
Imagine your child being hooked up to a feeding tube to 1, 5, even 10 years of age. Imagine your child not being interested in taking any food by mouth.
Imagine your baby having to have a stoma, not just as an infant, but throughout their entire childhood.
Imagine your baby having multiple surgeries, being in hospital for many months at a time. This could impact their learning, their feeding, walking, crawling.
These are children with intestinal failure.
So we're thrilled to be here today to talk about a program we're currently working on, the Manitoba Intestinal Rehabilitation Program. I'm Dr. Griffin, Jennifer Griffin, a pediatric gastroenterologist.
And I'm Anna Scheuer from Pediatric Surgery, and we have no disclosures. So we're just going to talk a little bit about a few things today. We're going to talk about what is intestinal failure, why it's important that we have an intestinal rehabilitation program here, and then we'll give you an overview of our proposal.
So what is intestinal failure? It's either not having enough guts or having guts that don't work. There's lots of different causes, and necrotizing enterocolitis, which is our focus today, is a huge piece of this. And there's a lot of other causes that vary from anything from gastroschisis and intestinal atresia to volvulus inflammatory bowel disease or malabsorption syndromes.
So in Manitoba, intestinal failure affects about 25 kids out of 100,000 live births, and we have almost 20,000 live births a year. Our prevalence is increasing, the kids that we look after, due to increased survival. The cost for 1 year for our inpatients is approximately $1.3 to $1.5 million, and that's just a small handful of kids that we treat. And as previously mentioned, our average initial hospital stay is currently about 8 months.
So there's many complications of intestinal failure or intestinal surgeries. This can range from feeding intolerance, so babies who won't eat, can't eat, might have vomiting. They're dependent on IV nutrition or TPN. They may have issues with bowel obstruction, diarrhea, bleeding, intestinal bleeds, or bacterial overgrowth. They can have liver failure, often secondary to the need for the parenteral nutrition, and can because they're dependent on the IV nutrition, they have IV access through central lines and can have infections or blood clots.
But one of the ways that we can help these kids is by developing intestinal rehabilitation programs. So NASFGAN, sorry this is a little blurry where I cut and paste it, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition recommends that children with intestinal failure have access to an intestinal rehabilitation program. And so that's what we're setting out to do.
So intestinal rehabilitation programs have already been shown to improve the outcomes for children who have intestinal failure. There's been multiple studies already outlining some of these, the improvements that can be had. By creating an intestinal rehab program here, we hope to now shorten the days requiring IV nutrition, help these children achieve enteral autonomy, hopefully even sooner, shorten their hospital stays, and get these families home.
So because we don't have a program yet, we thought it would be very useful to meet with multiple stakeholders, many of whom are in the audience. We wanted to find out what the stakeholders thought would be important in an intestinal rehabilitation program, as well as us. And as such, we've identified needs from the stakeholders, needs from patients, and that's how we're going to build our program.
So our proposed Manitoba Intestinal Rehabilitation Program, or MIRP, would be a multidisciplinary team that manages children with intestinal failure who require long-term IV nutrition.
In developing our program, we've come up with our vision statement, our mission statement, and our values. To sum it all together, we really want to look after these kids while we continue to collaborate. We want to excel in clinical practice. We want to have a research component, and for certain, we want to advocate for these complex children and their caregivers.
Our proposed structure of how this program would run is once a week we'd have a large multidisciplinary meeting. This would include both of us. We're working on identifying someone for a clinician assistant role, would be key to the success of this program. And then you can see the list of other people who are, and many more really than this, who are involved in these children's care. That might be the dietitian who's following them, managing their TPN and other nutritional aspects, the primary teams that are following them, whether they're in the NICU, whether they're on the regular pediatric wards, and other allied health services such as pharmacy, social workers, and we'd love to involve actually the nurses who are providing a lot of this care for these patients, whether it's the charge nurse on a unit or the bedside RN.
So who's going to qualify for MIRP? So although NASFGAN had kids who were more than 60 days on TPN, the more acceptable definition now is any child or baby who requires PN for greater than or equal to 42 days. We've also put or anticipated because we don't want to wait until 42 days have gone by to be consulted, because there's certainly lots of strategies that we can help you employ before then. Or from the surgical point of view, if the estimated bowel length after surgery is less than or equal to 25% of that expected. But really anybody that you're worried about in terms of how they're going to manage with enteral feeds, we'd like to be involved with. How do you consult us? We originally had the fax number up, but then we decided we're not official yet. We still need to have hopefully one last meeting or so with program committee. So we will be doing a rollout and you'll know exactly how to consult us. It'll be faxing one of the offices with a consult attention MIRP.
Looking through our program goals, so ultimately we want to improve the care of children who have intestinal failure. We want to reduce the complications that they experience, shorten the length of stay and their time on parenteral nutrition. We want to help improve discharge planning by developing protocols, emergency care packages for the families prior to going home. We also want to continue to improve our own knowledge. You'll hear from someone who has experience already with intestinal rehab programs following us. And so through this collaboration with other intestinal rehab programs throughout Canada and even internationally, we want to then learn more and bring it back to share with you.
Just an additional plug, the conference in September that I went to had a great allied health day. So anybody from nursing or allied health, it's going to be 2020 in Toronto and it'll be a fabulous program. So we're going to have overreaching goals for the program, but weekly goals as well. So when we have our weekly meeting as a large group, we're going to discuss any current active issues. This would obviously include ins and outs, infection, making sure there's some oral stimulation going on if appropriate, review medications, long-term issues such as PN-associated liver disease, issues with central line care. Some of our units have been good at implementing protocols for that. Bone health, which often gets left behind, and also monitoring for development. Discharge planning is key for these kids and families because right now this is one of the stumbling blocks to getting them home sooner. So we want to be able to work on our TPN teaching program, our central line teaching, as well as trying to find a disposition for these children. And finally, social determinants of health are incredibly important for these families who have complex kids and they spend months and months in hospital. So looking for financial supports, any family supports and barriers to accessing care. As we do this, we'll discuss the options for management with the multidisciplinary team because we really want a collaborative care plan. This is not Jen and I parachuting in, but we want everybody to be involved in how we look after the kids. We want to be able to document these suggestions in the chart because right now we chat about things at TPN rounds, but we're not formalized yet. And we'd really like to strengthen communication because with multiple healthcare providers, as you all know, it can get a little confusing. So one of our real goals is to try to streamline communication.
So now you kind of have an idea of what our vision is. Ultimately, summarizing what are our goals. So for patients and caregivers, we want to help coordinate and collaborate care amongst all of our different teams and help streamline their care, help families understand what is happening and what might happen in the future as we move through. We hope to have regular meetings with families, face-to-face meetings, to help with this communication and bringing all the different teams' messages to the families and helping them understand that. And in that way, enhance discharge planning so that we can get patients out of hospital sooner. So if parents are aware, families or caregivers are aware of what the goals are, they can already start making adjustments to family life, where they're living, what supports they have in place.
And MIRP will help you as well as for the healthcare providers. Some of this we've gone over as well. We want to develop protocols. So protocols is in quotes because each patient is very unique, but as much as we can. We also have the resources from the Western Children's Hospital Intestinal Rehabilitation Program who are willing to share. So we don't have to reinvent the wheel. There's lots of resources that we can use already. And as we said, we're happy to help make sure that all the consultations are going to be in place, document our notes, both at our weekly review and also prior to the weekend. And as Jen said, we really want to make sure right from the get-go we have some good family meetings, because our families that we've managed to institute this with already, starting at about 2 weeks after admission, have found it very helpful to meet regularly. Some families have slipped through the cracks and haven't had a family meeting until fourth month of hospital stay.
We missed our main slide, but our tagline is we want to help these children live better and live longer. Thank you.
There we go.
There's definitely time for questions if anyone would like to come up to the mic. I do want to ask you, the thinking is evolving as to how much gut is enough gut, and what could you, when large segments of gut are necrotic and have to be resected, we're always a little terrified. What can you tell us to adjust our thinking on this?
Well, I think it's a great point, and I think it's an evolution, and Jen and I are obviously both pretty junior, so things have even changed since we started our training. The biggest change really has been novel lipid strategies. So with Omega-Van and SMOF now, we don't see the same rates of liver disease, which often prove fatal for these children in childhood. So you might get them out of the nursery, but by age 7 to 10, they were dying of liver failure if they weren't getting a transplant. We don't really see that anymore. So in some ways, sort of no gut is too short in that there's many salvage strategies. It just becomes chronic disease, and it is fraught with a lot of complications, and the parents or caregivers really have to understand how that will impact their child and quality of life, which is always a moving target. So generally, I think surgically now we would advocate for taking out what you need to take, unless everything from the from the stomach down to the rectum is dead. If you have 10 centimeters of small bowel, you're still survivable. For now, transplants are not great, but that is also something that has intense research involved. I think the other thing to add to that is just because you have a lot of intestine doesn't necessarily mean it's going to work well. And that's our biggest challenge is you could have 25 centimeters and do great and be off PN, and you could have 120 centimeters and be PN dependent for 10 years. So that we don't really have a way to predict. So for now, we'd advocate certainly having a good discussion regardless of bowel length. Go ahead, Richard.
I want to congratulate you both on what you've done so far and what you're trying to accomplish, and I think that's great to establish a program like this. I have a question, I know you're just getting started, but this is kind of after the fact, right? The kids have short gut, and then we're going to deal with the trouble. Do you see a role for MIRP pre-fact, like in prevention and trying to pick out the kids that might end up in MIRP if we don't or do certain things? You know what I mean?
That's a fabulous question. I think, and I'm obviously thinking on the spot here, having a database would be great, because we'd probably have to start and look back and see which children end up as intestinal failure children, and then look at what were the preceding events that led to that. If we can identify what events typically precipitate intestinal failure, then we can probably look at mitigating factors for those.
Okay, good.
There may be some other databases that we can draw on for that, or other centers that are ahead of the game on that.
It might be it's an excellent question, but maybe very challenging to answer, because can any of us predict, right? And that's where maybe the database can come in, and looking how can we predict who might go one path versus another.
Well, I mean, if it was easy, then we wouldn't need you.
Right. Yeah. The one thing we didn't really introduce in this topic, but we have for, depending on who we're talking to, is the clinical arm is the main arm, but luckily our patient population is not huge, so we'd like to establish a database so we can follow our patients prospectively. And then the surgical congenital anomalies database has kindly said that they would support us through piggybacking their platform, as there's a lot of overlap between the kids. So that's something that once we get our program going, we should be able to get up and running pretty quickly.
Yeah, so what do you think would be the criteria for consultation right now?
For us is a PN either on or expected more than 42 days, or bowel length less than 25% expected. So for example, if you have a neck baby who's a 28-weeker and weighs 1,200 grams and has an operation, chances are they're going to be on PN. They've already probably had a couple weeks under their belt, so they're definitely going to get another couple, so consult us. We'd rather be at the beginning consulted too much, and then if we need to tighten that up, we're happy to accommodate that.
Well, we've created a business plan, so once we get the okay formally to roll this out, then we'll have all the criteria written out so that it's just distributed to all the different departments.
Hi, my name's Tanya Tikon. I've heard you guys speak before, and I guess I'm critiquing your speech, so just a titch. And what I walked away from last time I heard you guys speak was hopeful, because I heard how SMOF doesn't prevent liver failure, but I also heard, which you didn't mention here, is how the bowel can still grow. So when I came from adults, if you had an accident, you lost your bowel, you were done. So whatever was you got, and you never got off TPN if you had so much gone. So I'd like you just to expand a little bit on that, because when I've gone around to the ward after listening to you guys, your presentation a couple months ago, I felt it gave me hope, and it gave all my colleagues hope, because they were like, oh, good, because we were wondering if we were dooming these children to be on TPN their whole life.
It's a great point. There's many parts of our ideas around this program we cut out of this talk in particular, but I think very relevant. I think, so we know that children have an amazing capacity for bowel adaptation, and so many of our children, our goals are actually not to just maintain. Our goals are actually to wean as much as they're capable of, and every child is different. So our hope and our goals as we follow, because Anna and I are both part of the home TPN program on the outpatient side, is to get these kids off or limit the amount of parenteral nutrition that they require. And even in hospital, we talked about some of the studies and outcomes that are impacted by these intestinal rehab programs, and they have shown that the children who we can actually achieve enteral autonomy, so get off parenteral nutrition, rather than having to go home on it, they can do it earlier, and we can actually save them anywhere from 1 to 4 weeks of a hospital stay, and that's not the patient only, but it's also the family and the hospital too, right? That we're helping the movement through hospital, we're helping children achieve these goals earlier and minimize the complications that are associated with a lot of the treatments that we do. Is that, yeah?
So I think we calculate we have about 16 kids a year who would end up coming through MIRP. About 4 kids out of those are discharged home. A year? Okay, so 30 a year that come through MIRP, but only 4 actually go home on PN. So most of them were able to wean off throughout their hospital stay, which is still pretty lengthy. And then because these kids stay in the program for some time, our outpatient clinic has gone from half a day every other month to a full day every month, and now we're expanding to another half day every month. But out of our kids that we follow in the outpatient, there's about 15 or 16 of them right now. This year, we have a couple that are super close, that are just down to about 2 days a week of TPN. We're closing stomas, and we're hoping to get probably another 2 off, probably in the first 6 months of this year. So these are kids who are now about 2 years of age who are getting off TPN, and some of them are tube fed, and some of them are just eating pretty much regular food except for sweets. That's the one thing that we really have to be cautious, and we haven't introduced those again. So and other than that, they're great kids. The clinic is mayhem, and they run around, and they have ports and G tubes, and they go to school, and they do all sorts of fun activities, and they really have a great quality of life. Okay. Yeah. Any other questions? If you want to contact the program team on our behalf, go for it.